Up next, Magnus Ohman is joined by Dr. Win-Kuang Shen, professor of medicine at the Mayo Clinic in Phoenix, Arizona. They cover role of AV nodal ablation and pacemaker therapy in the elderly.
Welcome to ACCEL, Win.
Thank you, Magnus.
So we have a lot of elderly patients, and they're getting more and more every day. And rapid atrial fibrillation can sometimes be a real challenge. Go through with me a little bit about the algorithm that you think about in the elderly. So remove the young for a little while here.
It's a tremendous population impacting on the society at an increasing rate. And atrial fibrillation, as we all know, the most frequent arrhythmia abnormality in this population. We know that the algorithm or the options that we have today when it comes to atrial fibrillation therapy, we talk about management for rate control, we talk about management for rhythm control, while of course there's a very big element of stroke prevention. And all of us know that when it comes to the treatment for either rate or rhythm control, to the most part, we don't quite have these treatment effectiveness perfected in any way that would be satisfied by the patients or ourselves. And so as a result, that we all often struggle about how to treat this population, particularly in the elderly.
And you make a very good point here in that the elderly are very, very hard to manage medically. But before we get into the medical management of the AFib, let's forget about anticoagulation for now. Let's talk a little bit first about ablation. Is there a role for ablation of AFib in the elderly in this setting?
The answer is yes. And as we get older, though, that the selection of the patient is really the key. We know that currently that when we ablate atrial fibrillation, most times, if we look at all the observational studies, as well as the several small randomized studies, the average age is in the range of upper 50s to mid 60s. And so we really have not been primarily targeting ablation of atrial fibrillation in the elderly patient population. On the other hand, as we all know, that there are some very active older patients that we may not consider them as elderly, and they are not frail, they are very active. So for ablation, the answer is yes, but it has to be very selected. But to the bulk of the population is, I think, what we're talking about, what is the role, and whether that there's an increasing role for the AV node ablation and pacing.
How frequent is this condition of rapid atrial fibrillation that you can't really easily manage with, let's say, beta blockers or calcium channel blockers?
Very often. Perhaps that I could invoke the Affirmed Trial. That the Affirmed Trial, the mean age of the Affirmed Trial was about 72. So that's, I think, close to the median age of the American population, which is at age 75. I think many people remember this really was a landmark study of Affirmed that testing the hypothesis of drug therapy for rhythm control versus rate control. The bottom line is that there was no difference when it comes to mortality, and there was no difference when it comes to stroke prevention. But what is really important, often that's not talked about, is that crossover rates were enormous. The patients underwent rate control for pharmacological therapy, were not happy, and had to go to rhythm control, vice versa. And the crossover rate that in one direction was about 35% in 2 years, in the other direction was about 15-20%. So this population, older patients with atrial fibrillation, pharmacological therapy for either rate or rate control is not good enough.
When you have patients, therefore, who you try the standard drugs and you can't control their heart rate, how do you review the heart rate? So obviously they come to clinic with AFib and they have sort of average rate of 88 on AFib. Are you satisfied with that, or do you actually get a Holter to try to understand how well their controlled is?
So this is really a point of discussion at many different levels. And we know that there's been one randomized trial really asking the question, lenient rate control versus more strict rate control. While lenient rate control, by definition, those patients with the resting heart rate that on a Holter or ECG, that less than 110 beats per minute. While in the more strict rate control, the definition was that the resting heart rate need to be under 80 beats per minute, and while with exercise, moderate exercise, less than 110. Jumping to the end point is that there was no difference when it comes to end point with a very composite end point, mortality, hospitalization, and such, and yet was the hospital admissions and office visits were much more frequent among those patients that randomized to the strict rate control.
So you would advise, in general, to get some idea of the exercise level of heart rate and so on and so forth in this setting to make sure that they stay out of the hospital at least.
Correct, and also, of course, patient symptoms. So in the patients who are not very symptomatic, I tend to be more lenient. For those patients who are very symptomatic, and then you have to do something.
How effective are other antiarrhythmic agents, not now for rhythm control, but rather for rate control? I'm thinking mostly amiodarone, but there may be others. Are they highly effective?
The answer is that the question is always whether that it's worth the risk using amiodarone for rate control in these patients. As we know, the long-term side effects of amiodarone sometimes can be quite significant. The answer is that in some patients, the amiodarone can be moderately effective in controlling the rate. The question is always the risk versus benefit.
And that medication has a lot of side effects.
Correct.
So you would advocate, therefore, to maybe think about AV nodal ablation and a pacemaker early on. Tell us a little bit more why you see the value of going sooner rather than wait.
So just very quickly, historically, we know that patients reached the end of the road, so to speak, failed drug therapy and perhaps even failed ablation, that this AV nodal ablation approach with a pacemaker is very effective in improving patients' symptoms and increase or improve their exercise capacity. And there was always a question about whether that creating a complete heart block when patients now are pacemaker dependent, whether that impact longevity. The answer is that we had a very large, not randomized observational, but case-controlled study demonstrated longevity where survival were not affected. And so as a result, that this approach, at least in the population who are very symptomatic, who have failed other means of treating atrial fibrillation, it's really a class 2A recommendation today. The question really you asked is a very important one, is that in this patient population, older patient population, the disease or arrhythmogenic substrate is very diffuse, and the pharmacological therapy is not very effective. While ablation may not be the best approach in these patients because diffuse substrate and success rate is low, complication rate is high, and whether that we take this that at an earlier stage and perhaps fail one attempt of pharmacological therapy, go to AV nodal ablation pacing, and I would anticipate will be very effective that when it comes to improving patients' symptoms and reduce hospitalization, unnecessary office visits.
It's a very good summary, and of course AV nodal ablation of this type is a relatively easy procedure. It's a very good summary on a complex problem. So maybe we need to think about AV nodal ablation a little bit earlier in the treatment strategy.
I certainly would support that.
Well, thank you very much, Win. It was great to visit with you today.
Thank you.